Grant Larson here. I'm here with Dr. Peter Shaw, and we're going to talk about the ShawLens today. Peter, welcome.
Thanks, Grant. Good to see you again.
Tell us about the research that you've spent so many years on and how you've arrived at the ShawLens.
Well, my background is an optometrist, and I've been in practice for a long time. And I also have a passion for photography and computer science and physics. And I took all those three things together when I was about 10 years ago and used the skills that I've learned and been taught into examining optics and how lenses actually affect how eye movements occur behind eyeglasses. So back in school, we all learned about optics. We used what are called paraxial optics, and we learned about anisoconia, and we learned about binocular vision. And in my practice, I noticed that a lot of patients were having problems getting used to relatively simple prescriptions, and I couldn't figure out why using the skill set that I learned in school. So being a bit of a closet engineer, I decided to pick apart optics and pick apart the mathematics of optics and quantify how patients move their eyes when we give them glasses. And this eventually evolved into what is now called ShawLens.
One of the primary benefits of the ShawLens is the treatment of anisoconia. Tell us a little bit about that.
Okay, so anisoconia is an interesting and much misunderstood diagnosis that optometrists are confronted with every day. Anisoconia comes in two flavors. We have the anisoconia of the object size, and then there's the anisoconia of how your eyes look around the world and take in our peripheral vision. We have names for that. The size issue is called static anisoconia, and static anisoconia, when present, inhibits the brain putting the images together if the image is stationary. And that results in some loss of stereopsis, maybe suppression, and can be instrumental in delaying the treatment of kids with amblyopia. Dynamic anisoconia may be also referred to by some people as prismatic effect, and it's also common in eyeglasses of differing prescriptions or anisometropia. As the eyes look around, we induce different amounts and direction of prism. For example, on up gaze, I might get base down prism, down gaze, base up prism, when I have a differential prescription in each eye. So it's the combination of dynamic and static anisoconia that I looked at in designing a lens system to make glasses more comfortable and more easily adapted to by patients of optometrists. Now, anisoconia has other issues as well. Just because you have a patient with anisometropia doesn't always mean that you have anisoconia. And just because you have anisoconia, it's not always caused by glasses. It can be caused by detached retina. It can be caused by a maculopathy, like an epiretinal membrane. There are many different causes for it, and I've developed a method or a toolkit for the optometrist to use that he's able to differentiate the diagnosis and apply the appropriate treatment for ocular diseases and diagnosis from a medical point of view.
Amblyopia is another area that the ShawLens is quite effective in treating.
Absolutely. In order to treat lazy eye, amblyopia, we have to provide a solid foundation for binocular vision. Amblyopia is a binocular disorder. Amblyopia does not exist in the monocular patient. So we need a binocular treatment to treat amblyopia. So if we equalize the cortical images, we get what's called sensory effusion. Sensory effusion results in what's called binocular summation. That means that the weaker eye is assisted by the good eye, and the amblyopia, which is thought to be a result of suppression of a blurred or an outsized image, is treated because now we've equalized the image sizes. A side benefit of providing equality in size of the image is we also reduce the prismatic effect. So kids who are wearing our lenses report much faster treatment of amblyopia. In fact, we have over 1,000 amblyopic kids who have now been treated with our lenses, and we get feedback from kids. I get little cards back in our Facebook site thanking me that kids can now see out of both eyes, and they don't have to wear a patch. See, a side benefit of treating the amblyopia and equalizing images is that patching now becomes often redundant. Treatment is relatively rapid, and we can monitor that, and it's up to the optometrist to guide the patient's treatment whether or not to patch.
Benefits to contact lens wearers.
Well, as you know, contact lens wearers tend not to like wearing glasses, and it's not just cosmetic. Contact lenses are by nature isoconic and isophoric. That means, like our lenses, they don't induce any size difference, and they don't induce any rotational differences between the two eyes. When contact lens wearers put their glasses on, all of a sudden their eyes have to work harder. Now they have to converge, diverge, and do vertical movements that they may not be used to, in fact become a bit lazy. So this muscle laziness is a consequence of having good vision. Okay? When we put glasses on, now the eyes have to adapt to the distorted world of a pair of eyeglasses. The images are curved, different sizes. Glasses do a lot of bad things to our vision. So if we can make glasses that reduce the amount of binocular magnification and rotational differences, the patients are happier. Also, as many of my colleagues have experienced, high index lenses with minus prescriptions cause a lot of barrel distortion, a lot of curvature of the field. That's because they're on a very flat base curve. Our patented technology optimizes the base curve to reduce the amount of barrel distortion. So patients are happy with thin lenses because we manage the barrel distortion common with high prescriptions and high index lenses. So that's sort of part of what we do. I should mention that all of our lenses are designed by a 3D modeling system that's computer-based, and we optimize the lens design to address not only the image size but also the binocular distortions, and that's a patented process that was recently granted our patent in January 2014.
You've talked about a lot of optical benefits. You've talked about some diseases that are not all that prevalent within an office. From your experience, from ShawLens users, from ShawLens practitioners, tell us about how they're being used in the practice, how they fit into their scope of all the lenses that they use.
Well, I'm the first to admit that we are not the first lens choice most doctors pick up. We are often a lens reserved for their complex and toughest cases. And the reason for that is quite simple. One, the doctor's established a relationship with a company, and he gets very competitive pricing. At this stage in our development, our prices are a bit higher. Our delivery times are a bit longer. Sometimes our lenses are a little bit thicker than regular lenses in order to create that magnification difference. Some practices use us as their primary lens. But what I would suggest for most practitioners wanting to integrate some of our advanced technology into their practice is to use it selectively with patients who have problems. It's a great way to help a patient remain in the practice rather than going online or to a big box store. So the examples would be a post-cataract patient where one eye has a cataract done, the other one hasn't. So perhaps the right eye's +2, left eye's plano. We're an ideal lens for that patient. A patient who is a contact lens wearer, who's perhaps -4 in one eye, -5 in the other, very common scenario, we will be much better than somebody else. And if the doctor communicates that information to the patient through our point of purchase pamphlets, then it makes it easier for the patient to go research on the web what we say. Then they come back to the practice saying, yep, I want that ShawLens, and you don't have to do the selling as a practitioner. You just sit back and say, well, you've got a cataract, or you've got monovision secondary to your refractive surgery. One eye's plano, one eye's -2, but the patient wants driving glasses for nighttime. If you just gave them plano -2, good chance they'll be suppressing and lose their stereopsis. With our lens, they won't. So what happens now is they can go on research that with a pamphlet and come back and become a patient that wants to buy from your practice and isn't looking for the lowest common denominator of cost and service and value, which they can get online or at a large optical chain or a large big box store.
As a practitioner, you've thought through how to make this as easy as possible. It's pretty complicated when you look at the optics and the physics that goes into it. Tell us about some of the tools that you've developed, you have for practitioners to make this as easy as possible.
So it is a very, eyeglass lenses are very complicated medical devices. In order for us to work best, we need to know exactly how the lenses fit on the face, what the diagnosis is, and whether or not our solution is going to be effective. So we ask the doctor to apply some simple optometric metrics into the design of the lens that helps us make better lenses. So we need to know things like, obviously, the frame shape and size, where the frame fits on the face, and we've developed a series of templates on the computer where the doctor can easily determine what the face form angle is, what the vertex distance is, and what the panoscopic angle is. Plus, we also ask for some optometric findings. What are the divergence amplitudes? Divergence amplitudes are very helpful in determining whether a patient has or doesn't have adapted dynamic anisoconia. If they've got low divergence amplitudes, then chances are they'll be a very poor adapter to anybody else's lenses, and our lenses will shine. If they've got very good divergence amplitudes, then maybe they can wear anything. So it's an easy way for the doctor to determine if there's a benefit to our technology that outweighs the additional cost, because we're all worried about cost, of a traditional lens. You know, what doctors don't like to have egg on their face. So if I say to a patient, well, you can't wear a Costco lens, for example, because it's not as good as mine, then they go to Costco. And Costco sells the very same lenses that optometrists sell most of the time. So you're selling the same product. However, if there's a benefit to a ShawLens for the patient, then the patient gets a second pair from Costco or Walmart or whoever, then he's going to see that, oh, there's a huge difference between the ShawLens and the other lens. And that lends great credibility and great custom for that patient to stay with that doctor forever. It's like the early days of contact lenses. Only optometrists were able to fit contact lenses successfully back in the 70s when I graduated. Okay. Nowadays, it's become an online relationship. Just the tough ones get fit by optometrists. Well, glasses are tough as well. In fact, glasses, I think, are tougher than contact lenses in many ways.
You've developed a very unique solution. Tell us little about, humility-wise, tell us a little bit about the wow factor that's being reported back from some of your patients.
Well, it's wonderful to hear that when an 8-year-old child of a colleague of mine comes back and says, my ophthalmologist, who's a pediatric ophthalmologist in Toronto, says I can burn all my patches. This kid had been a non-performing amblyopia for 4 years. 6 months in ShawLens at the age of 7, and she's 20/20 in both eyes. You know, she was ecstatic. Her mother was ecstatic. Our bookkeeper, her daughter, she's a meridional anisometrope with amblyopia, with lazy eye, and she was always suppressing. She put her glasses on for the first time about 1.5 years ago. On Monday, she says, Mom, getting a bit of a headache because now for the first time I can actually see out of both eyes. Now she's 20/20 in both eyes with full binocularity. That's 1.5 years later, and now she's getting another 2 pairs of glasses. Another patient, this is an interesting case. He's an older farmer. He's in his 60s. And like many farmers, he takes his job seriously. Well, since he started wearing our lenses, he became Canada's champion plowmaster. He can make the straightest farrows ever. He could never do that before. Now he's in France this month for the World Championships with his tractor, making straight lines in the fields. So these are just some of the stories that make me very happy, and there's thousands of them. I mean, we get so many letters coming in, I can't go through all of them, but it's pretty amazing. Now, and the good news is that most of the accolades go to the doctor. They don't come to us, because we try to work behind the scenes with the doctor, because the doctor tells us what they need. We just provide it. Of course, we help them a lot. We give them software. We give them tools to make that happen.
Peter, you're so involved in this business in so many aspects. Would it be a surprise to anybody that if when they called into ShawLens that you didn't pick up the phone?
Well, I answer my emails. I must admit, yeah, I do answer the phone. I love to hear stories. I always talking to patients on the phone and referring them to our partner optometrists all over the world. They want to come and see me, but I don't want to see them. I'd rather that they go and see their local optometrist. I can work through the local optometrist. It doesn't cost you any money. It's a simple way to get started, and we're always there to stand behind you, the local practitioner who can provide that care for a lifetime.
Peter, I want to thank you for sharing with us the ShawLens experience. And you can see more information on www.shawlens.com.